I'm very happy to talk about clinical relevance of liquid biopsy in cancer patients. So I would like to start with this scheme where you see that as soon as you have a primary tumor, you may have more aggressive cells that are released by these tumors. They will grow to the bloodstream and they may reach some distant organs. And it's what I represented in the liver, for example, bone marrow and lung. For example, in breast cancer, you have really these sites of metastases. And of course, then we change the color because as you see, when they are in these organs, they may change their genotype and phenotype. And that's why then they might be different, and talking about heterogeneity already in the primary tumor, but also in metastatic sites. What is interesting is that these cells might also circulate again through the bloodstream, and that's why we came with this idea of this real-time liquid biopsy, because with a non-invasive blood sample, you have a pool of cells coming from the primary sites, but also from the metastatic sites. That's why you have really a pool of cells that are really different, heterogeneous, and coming even from sites that you don't know that exist. What is interesting as well as a new way to think of cancer is that these cells might go again to the primary sites. So when we talk about local relapse, sometimes it's not cells that are really just missed by the surgeon or the radiotherapist, but it's more that you have cells coming back from distant sites to the primary sites. And again, you have a completely different primary tumor here that is called now a relapse. And what is important here is that the genotype and the phenotype of the Ctcs and the primary tumor is frequently different. And the last speaker talked about that, and of course I will go through examples where you may have, of course, different explanation for that. And that's why the liquid biopsy can really add more information, and you can do, of course, these blood samples frequently because it's non-invasive. Of course, at the end, we will see the clinical relevance of that. Just to say that we coined this terminology, liquid biopsy, for the first time in 2010, and it has been said again this year by the former president of the ASCO, Dan Hayes, in this article. So if you look in the PubMed, you have a lot of articles these days on Ctcs, but also ctDNA and exosomes, because we mean that all these circulating biomarkers are really complementary. So I was asked several times, what is the best? For me, there is not a best circulating biomarkers, because I still feel that in the future we will combine all these different circulating biomarkers because they give all different information. So that's what I mean today. Just what is interesting as well is in clinical trial Gov, you can see all the completed but also active clinical trials using Ctcs and ctDNA, which is very important in the cancer research field. What you may know, but it's not really used in routine yet, there is a TNM classification for these circulating tumor cells or disseminated tumor cells in distant organs, which is CM0I+. Because you have no metastatic sign you have no metastatic site, so CM0, and I+ for isolated Ctcs or disseminated tumor cells. If we look at the biology of Ctcs, it's easy. You have the way to avoid aneuploidies when they are leaving the primary tumor or the distant sites, but they may undergo the EMT, which is they go from epithelial to mesenchymal for some subset of Ctcs. They might be invasive as single cells or as clusters or microemboli. And of course, as we heard already, they are very heterogeneous, and some of them, we will see that more precisely, have the ability to renew and to give rise to distant metastases. What is a technical challenge? They are very rare. So it means when I say very rare, you may have, for example, 1, 2, 3, 4, 5 Ctcs in 7.5 ml of blood. So it's really a challenge, and that's why you have, and I will not go through details, you will have different steps to enrich these Ctcs, because you cannot really work on the whole blood like that. So either you will use the biology of these Ctcs that are different from the leukocytes, for example, or you can use the physical properties of these Ctcs that are different as well. And that's a nice way to enrich Ctcs. The second step will be to detect them, and again you have three main ways to do that. You have the immunocytological technologies, you may use molecular biologies, or you may use functional assays. And just to focus on that, to let you know that we are really expert in the functionality of CTCs for many years, and it's really coming back in the main meetings. Why? Because we still believe that it's important to detect the viable CTCs because they are able to give rise to distant metastases. And we just optimized a new way to do that at the single cell level, which means that we need to enrich CTCs, whatever you want, but then we will use the EpiSpot in a drop, which means that we will do like a digital PCR. We will encapsulate CTCs in microdroplets. At the end, you can have a staining of the cells, so you may detect them as a total number of CTCs, for example, EpCAM, specific for epithelial cells, but you can see also what they secrete, release, or shed. So they are all functional. When you see a green line, like here, for example, sorry, if you see a green line, it means that they secreted PSA and you have a beautiful staining of epithelial cell adhesion molecule. So you may see also the EMT CTCs, which was a challenge these last years. And we just got some money to validate this new technology in prostate cancer patients from the SATA-XLR in France. So to go on with the clinical application of CTCs, you see that you have many of them in addition of ctDNA. For example, it would be nice whether we are able to detect early cancer. So it's screening and early detection. Of course, we have some, I would say, first example of that, but it still needs to be validated because we still know that you have accumulation of mutations where you are older, you have even mutations coming when you have benign disease. So it's not so clear whether we have a test already to screen and to replace, for example, mammography today. So it's really something that we are working on, but it's not yet ready. The second is really important, real-time monitoring of therapy. It's important as soon as you give a treatment to a patient to know quite early whether the treatment is efficient or not, and before, after 3 months, for example, the radiology. Then the risk for metastatic relapse, so you may have prognostic information at the time of the diagnosis of the cancer. Of course, therapeutic targets and resistance mechanisms, it's very important to know when you have CTCs emerging, for example, and you see a new expression protein or loss of protein expression, you may already see a relapse for your treatment. And we heard before for HER2/neu, and it's really a nice example because you may have, for example, primary tumor that are negative for HER2/neu amplification, but you have many CTCs, for example, positive for this amplification. And we have two clinical trials, one in Germany, one in France, treating patients, breast cancer patients with HER2/neu amplification only on CTCs, but not in the primary tumor. And of course, we will see whether there is a benefit for these patients to get the trastuzumab. And finally, stratification and therapeutic interventions. So it's really the definition of precision medicines to give the right treatment at the right moment to the right patient. And of course, what is written on the right side is important as well, the complementarity of the different circulating biomarkers, but also you have many, many different tests for CTCs, for ctDNA, and what is really important today is really to have also these new assays validated in different groups, because otherwise it's easy to say, okay, I have a very nice test, but nobody tested it. And it's really a problem today. And also, when you build an interventional clinical study, it's important as well to demonstrate the utility of liquid biopsy, because you have many, many clinical trials where everybody can observe that it's better to have no CTCs or no ctDNA than to be positive for this biomarker, but it's important to also demonstrate the clinical utility. And of course, the therapy must work, because it was the example of the SWOG in US, where they said, okay, the CTCs are not so good because it was really not really giving the right results. But of course, if you have not the right chemotherapy at the last line of your clinical trial, whatever you will test, it will not really discriminate the right of the responder and the non-responder patient. So therapy must work. It's very important for the design of the study. So let me show you some examples. For example, clinical relevance in early stage of cancer patients. So it's important to say that, of course, you have many positive data in advanced stage. But here, talking about early stage, so detection, for example, of CTCs in neoadjuvant breast cancer therapy. You see here with this quite recent work that the CTC counts provide prognostic information independent from the PCR, which is quite important. And it has just been validated by an international meta-analysis on more than 2,000 patients. So it means 21 studies and 16 centers. And what you can see here as a sum up of this study is that you have really worse survival when you have CTCs, but what is interesting, if you see here, it's more than you have CTCs, worse CTs, but you see already with 5 CTCs, which is not too many if you think of it, 5 CTCs in 7.5 ml of blood. But already you have some a very high increase, 6.25 hazard ratio to get metastatic sites. So it's very important data. Then detection of minimal residual disease. Of course, it's important to be able to follow these patients after the treatment was initiated. And again, it is a very recent data just published showing you that CTCs detected 2 years after adjuvant chemotherapy could really also distinguish the good and the bad responders. And again, it's very important to have this data and to follow this patient after therapy. What about clinical relevance in metastatic patients? And again, it's important to detect and monitor CTCs during in metastatic patients. Of course, you have more chance to get CTCs and you have more patients positive. And just the example about therapeutic targets, you can follow, indeed, as I gave you as an example, HER2/neu, but I will go through PD-L1 as an example and androgen receptor variant 7. So let's start with PD-L1 on CTCs. We were the first one a few years ago to show that we are able to detect CTCs expressing PD-L1 in the blood. Of course, you know very well that you have this camouflage of the tumor cells in front of the immune system by expressing, for example, PD-L1. And as soon as you have this interaction, these cells are not recognized anymore. So the idea of the immunotherapy is really to cut this interaction by adding these antibodies. And of course, it's very important because it has been highlighted by this Nobel Prize a few weeks ago. So we use the cell search system, which is the only one approved this year, up to date, FDA approved in US for CTC detection. So we use the last channel to add the protein you want to detect. So you see that we added PD-L1, and you see again heterogeneity because you have, for example, in the same metastatic breast cancer patients, CTCs here, which is PD-L1 plus, CD45 neg because it's specific of leukocytes. You have a nucleus dapipos, and of course cytokeratin is positive. So you have really a CTC expressing PD-L1 here next to a leukocyte expressing PD-L1 as well, CD45 plus, nucleus plus. And of course, next to this CTC, you can have CTC negative for PD-L1. So again, heterogeneity among the patients, but also among CTCs intra-patient. So we could show that quite a high amount of patients at CTCs PD-L1 plus, and what was interesting, it was discordant with the primary tumor staining for PD-L1. So again, we could get more information on a new cohort to validate this data. It was presented at the AACR this year, where only the CTCs PD-L1 plus could really give some prognostic information for this metastatic patient in breast cancer, and the primary tumor was not informative at all. Just to show you again what is relevant at the clinical level is that last year we could show with our colleague in Athens that the absence of PD-L1 overexpression at the end of treatment was strongly associated with a complete response. So of course it's quite interesting to go on putting the liquid biopsy on the top of standard biopsy. Of course, it's interesting also to validate that at the clinical validity. So it has been done already in 2014, so it's already 4 years ago. It was really led by our colleague in France, Jean-Yves Pierga in Institut Curie, and they really used quite a high amount of patients to show that you have a clinical validity, which means that they detected Ctcs you see in metastatic breast cancer patients at baseline before the initiation of chemotherapy, but also just quickly before, after the initiation of this therapy, or 6 to 8 weeks. And it was compared to the standard tumor markers, CA15-3 and CEA. And you see that only the Ctcs had this prognostic information, and the tumor marker that are, at least in France, refounded by the Social Security was not. Another nice example is the expression of androgen receptor variant 7, and it has been shown a few years ago by Emmanuel Antonarakis. And what he could show that when you have this expression of this variant in Ctcs, you have really a resistance to abiraterone and enzalutamide therapies in prostate cancer. So what you see clearly here, you have a good response with these drugs when you have no Ctcs, so it seems to be okay. You have a moderate response when you have Ctcs plus, but they have not this splicing variant ARV7, and then you have a poor response when you have Ctcs with this variant. So it's quite interesting, and now even our chair in New York at the Sloan Memorial Kettering Hospital is really using it and work with Emmanuel Antonarakis. Of course, we go to this point, which is very important. It's the clinical utility of these Ctcs, and we are happy that we could run with Jean-Yves Pierga, as I said, in Institut Curie, a stick Ctc metabreast, which means that it's a medico-economic evaluation of the Ctcs involved in making the good choice for the clinician to give either endocrine therapy or chemotherapy. So it was really a study including 1,000 metastatic breast cancer patients, and we had two different arms. You see one where the baseline Ctc count was blinded, and the clinician has his own choice to give the treatment. But we had also baseline Ctc count disclosed, and of course we always ask the clinician what you would like to do, and if he said I would like to give chemotherapy, and we said there is 0 Ctcs, you have to give endocrine therapy. So you see it's really interventional clinical trial, and this has been now finished, inclusion, even the analysis. I am not allowed to give the data, but we have now an oral presentation at the next San Antonio Breast Cancer Symposium in a few weeks. And of course, it's a plenary session, so imagine that the data are very positive, so it's very good for the liquid biopsy field to show clinical utility. As a second point, we will start also in France another interventional clinical trial, this time on prostate cancer patients, where we will include quite a high number of patients. And here we will not have only one test, but many tests over treatments and decisions over the disease of the patients. To switch to circulating cell-free DNA in blood, of course you may know that they are released by dying cells, apoptotic cells. So again, it's interesting and it's important to know when to detect ctDNA. It's not the same as Ctc that are really released spontaneously, but actively by the tumor, the more aggressive one. And here you have really different markers that are released by dying cells. What is really important to notice as well is that you have a low concentration of circulating tumor DNA. So the same problems faced for the Ctcs is also to find the right SOP to enrich correctly the ctDNA among the normal circulating free DNA. And as I said before, it's not easy because you have, when you have older people, you have many new mutations and it's not linked to cancer. And also when you have a benign disease, you have a release of normal DNA more than usual. So again, many challenges in this ctDNA field. What is interesting is that you have these EGFR mutations that has been approved in June 2016 after this Douya et al. Work, this French work, where you have liquid biopsy to stratify non-small cell lung cancer patients for EGFR targeted therapy. But what you can see again is that you have a very nice specificity, but you have quite a low sensitivity, which means that when you find this ctDNA mutation in the blood, it's okay. You are sure that you have a primary tumor harboring this mutation, but if you don't find the ctDNA, you have to go to the primary tumor again with a biopsy to be sure that you have the mutation or not. Again, this year we had this piece of work which was really nice and highlighted everywhere, showing that we have, again, a combination of ctDNA and different proteins to have a better test, complementary information from different circulating biomarkers. What is interesting, you have a high specificity and sensitivity, for example, for ovarian cancer, but if you look carefully for example, already stage 3 localized breast cancer, it was really with not such a high specificity and sensitivity. So we are not yet at the screening of cancer, as I said before. Finally, identification of metastasis competent CTCs, it's really something that we really worked a lot this last year in our lab, because we still feel that it's important to target the right CTCs that are able to give rise to distant metastases. And again, not all CTCs are equal when they are traveling in the bloodstream, and many of them will die and don't have this potential to renew. So first we were able for the first time to establish a CTC line from colon cancer patient in vitro, and it was highlighted by the AACR because it was the most quoted article in 2015. So what we have is really a stable CTC line for a long time, and we could show that it shares important features with the tumor cells from the patient, also an intermediate epithelial to mesenchymal phenotype with stem cell properties. It could induce in vitro angiogenesis and, of course, tumors in immunodeficient mice. What we really questioned then, it was why they are so different from the other tumor cells in colon cancer. So what has been highlighted clearly is that they have stemness, strongly stemness here, but they have a strong link with metabolisms and mitochondria proteins, and also a specific way to repair DNA. So it was quite interesting data that we had. So the story not finished, because we have this first CTC line I just described. It was obtained before the initiation of the treatment, but this patient was followed with a first line of treatment, a second line of treatment. He relapsed several times, and we could get a second CTC lines here and 7 others here. So at the end we have 9 CTC lines, and it's a unique material because it's before treatment and during treatment and cancer progression until the patient died. What was interesting as well, as it is very difficult to get CTC lines, it's just to say that you see here, for example, the number of CTCs that you need to have in the bloodstream to get CTC lines. You need more than 300, which was a challenge in colon cancer because, as you know, you have really a capture of these CTCs in the liver. That's why you have a quite high amount of metastatic sites in the liver. So it was really a challenge to have a high number of CTCs in the bloodstream, in the peripheral blood, to get these CTC lines. And it has just been published last week, the comparison and the characterization of these 9 CTC lines at baseline, but also through the treatment and cancer progression. So at the end, our goal is really not to be able to make a CTC line for each patient. It doesn't make sense, and it's so difficult. It's really to see whether we can really highlight a new pathway to be able to know it, to block it with new drugs, and to eradicate the most aggressive CTCs, which is the ones that are able to give rise to distant metastatic sites. So at the end, I would like to highlight as well the fact that we are working not only on Ctcs, because as soon as you have a blood sample, you have the plasma. So we keep always the ctDNA, the exosomes, the platelets, which are really now a big family of circulating biomarkers. And in all our consortium now, we are really putting all these different circulating biomarkers together. And my hope is really to have like an index or an algorithm that we can calculate how many circulating biomarkers are present, and maybe how much important they are, how many CTCs, what is the number of copy of ctDNA, how many exosomes, and what is the information that we can get out of it. Exactly what I said, so it's really what we are doing, for example, in Cancer ID, a big European consortium where we work. We are more than 140 different institutions, and we are working on making with one blood samples really as many information as we can to drive correctly the therapy in the future. So I would just like to highlight all our projects. As I said, whether it's a European project, like here on the left side, with many scans that we run these days, or Marie Curie project, or IMI project. So it's always on the combination of these different circulating biomarkers in different cancer type, but also many different French proposal here, and also this new one, this interventional study coordinated by Stéphane Cullin in prostate cancer. And I would like to highlight that as well, because it's almost finalized and it will be the next step after Cancer ID. It was such a success at the European level that Klaus Pantel, one of the pioneers in the CTC field, is finalizing, building this European Liquid Biopsy Society. And of course, it will be like a huge consortium where everybody from America, Asia, and Europe can participate. And our main goal will be really to introduce liquid biopsy in the clinical practice. It will be important. And at the end, I would like to thank my people in the University Medical Center of Montpellier, and big thanks to the patient for donating blood, all the collaboration that we have all over the world for sure. And also I would like to highlight the next ESMRC conference that I had the chance to organize in Montpellier in France this year. It was really a big success with Robert Weinberg, for example, and Joan Massaguet, the director of the CLSC of New York. And it will be the next one in Shanghai, and I have the chance to co-organize it again. So thank you very much for your attention.